Good morning. Today's class we will be discussing the pharmacology of drugs used in the treatment of peptic ulcer. At the end of this session, you will be able to describe the different mechanisms of actions of the drugs used in peptic ulcer and what is the pharmacological basis for the use of these drugs. So we will begin the class with an overview of gastric acid secretion. As you learned in physiology, the gastric parietal cell is the one which produces gastric acid secreted into the lumen of the stomach. So what are the chemical or hormonal stimulants for gastric acid secretion? We have gastrin, also called cholecystokinin 2, acetylcholine, which acts through the muscarinic M3 receptors. Then we have the histamine H2 receptor. So gastrin, acetylcholine and histamine, all of them act through their different mechanisms, finally stimulating protein kinase, which works through the hydrogen potassium ATPase, which is the final common pathway of gastric acid production. So the anti-muscarinic drugs like pyranzapine and telanzapine block the M3 receptors and reduce acid secretion. Whereas the histamine H2 receptor antagonists like cimetidine, ranitidine, pharmacology block the histamine H2 receptor and decrease acid production. Whereas the proton pump inhibitors or PPIs like OMEPRAZOLE, pantoprazole, they block the final common pathway and completely stop acid production. That is, there is a 100% block in production of gastric acid. The other drugs which are used in peptic ulcer include the prostaglandin agonists, which stimulate gastric mucus production and protect the gastric mucosa. The antacids neutralize the acid which is already being produced. Then we have what are called ulcer protectants. These protect the ulcer cavity from further attack by acid. And we have antibiotics which kill the microorganism responsible in about 80% of gastric and peptic ulcer, that is anti-H. pylori antibiotics. So the classification of anti-peptic ulcer drugs is based on mechanism and site of action. So we have the antacids. Antacids neutralize the acid which is already produced. In that we have two groups, the systemic antacids, which includes sodium bicarbonate and sodium citrate, and non-systemic antacids like magnesium hydroxide, magnesium trisilicate, aluminium hydroxide and calcium carbonate. Then we have the H2 receptor blockers or the H2 antagonists, cimetidine, ranitidine, pharmacology, etc. Then we come to the most widely used anti-peptic ulcer drugs, the proton pump inhibitors, OMEPRAZOLE, lansoprazole, pantoprazole, S-omeprazole, and so on. Then we have the ulcer protective drugs, sucralfate and sodium bismuth subcitrate. Ulcer healers include carbenoxolone sodium and deglycerinized licorice. Then we have the prostaglandin analogs which stimulate gastric mucus production, that is misoprostol, inoprostol and rioprostol. Anticholinergics not very frequently used includes pyranzapine and telanzapine. And an important group of anti-peptic ulcer drugs include the anti-H. pylori antibiotics, namely amoxicillin, clarithromycin, metronidazole, tinidazole, and the tetracyclines. Now coming to sodium bicarbonate, this is a systemic antacid. Now why do we call it a systemic antacid? Because the bicarbonate ion is absorbed systemically and can cause systemic alkalosis. Sodium bicarbonate thus has these demerits or disadvantages. It can cause systemic alkalosis, Once the administration of sodium bicarbonate is stopped, it can produce a rebound acid production increase. The carbon dioxide which is produced in the stomach, that is sodium bicarbonate, will react with hydrochloric acid, produce sodium chloride, carbon dioxide and water. The carbon dioxide thus released will cause distension of the stomach, discomfort, belching, the ulcer can perforate, and the sodium which is absorbed can cause sodium overload. Therefore, sodium bicarbonate is no longer used. This is a 3-mark question. Sodium bicarbonate is used in the treatment of metabolic acidosis, useful in forced alkaline diuresis in poisoning with acidic drugs like aspirin and barbiturates, used in mouthwashes. It's also used as an antipruritic, that is to reduce itching, in eye wash solutions, and as a systemic antacid, very rare. The next, coming to the most commonly used combination antacid, contains aluminium and magnesium salts. This is a 3-mark question. Give reason. Aluminium and magnesium salts are used in combination as antacids. Magnesium salts are fast-acting, aluminium salts are slow-acting. Magnesium salts are short-acting, aluminium salts are rapidly acting. Magnesium salts have a laxative action, whereas aluminium salts have a constipating action. So aluminium salts, slow-acting, long-acting and constipating action. So for these 3 reasons, aluminium and magnesium salts are used in combination as antacids. Okay, this is what we have just described. H2 receptor blockers, among the first used was cimetidine. The mechanism of action is they combine with the H2 receptors of the parietal cell, thus inhibit adenyl cyclase activation, which decreases cyclic AMP formation in the parietal cell, inhibits protein kinase activation, there is a spelling mistake here, inhibition of protein kinase, thus decreasing gastric acid secretion. H2 blockers reduce acid secretion by about 80% because the acetylcholine and the gastrin stimulated acid production will continue. So there is inhibition of gastric acid secretion, all the phases, basal, cyclic, neurogenic and gastric phases are suppressed. Secretory response to acetylcholine, gastrin, insulin, alcohol, food, etc., which are mediated through the histamine receptor, are also suppressed by H2 blockers. So there is a decrease in the volume of gastric juice, pepsin and intrinsic factor secretion. H2 blockers do not have any significant effect on gastrin, lower esophageal sphincter tone, pancreatic secretion and gastric emptying. The common adverse effects associated with H2 blockers include headache, dizziness, nausea, muscle pain, itching and skin rashes. Especially cimetidine crosses the blood-brain barrier, resulting in confusion, restlessness, hallucinations, delirium and convulsions. On intravenous administration, bradycardia, cardiac dysrhythmias and very rarely cardiac arrest. Cimetidine was the first H2 blocker to be used clinically. So, cimetidine comes with some disadvantages. And what are these disadvantages? It has anti-androgenic activity. It increases plasma prolactin levels, decreases estrogen metabolism. So, the anti-androgenic effect can result in gynecomastia, loss of libido, impotence and temporary oligospermia. In addition to these, cimetidine is also a hepatic microsomal enzyme inhibitor. Because of these drawbacks or disadvantages, the use of cimetidine today is very, very less. The next drug in this group is ranitidine, which is very widely used. Now, what are the advantages of ranitidine over cimetidine? It is 8 times more potent than cimetidine. Ranitidine is longer acting, does not inhibit hepatic microsomal enzymes, and has no anti-androgenic action. CNS effects like hallucination, delirium, and confusion are mild when compared to cimetidine. And the usual dose of ranitidine is 300 milligrams once daily at bedtime or 150 milligrams twice a day. The usual dose is for 2 months. Also given intravenous or intramuscular 50 milligrams. Nizatidine, famotidine have some very minor advantages over ranitidine. 4 times more potent than cimetidine, high oral bioavailability, excreted unchanged in urine, therefore safe in patients with hepatic disease. Roxatidine, more potent than nizatidine. Absorption is not affected by food or antacids. So those are the different H2 blockers, of which ranitidine is the most widely used. Now what are the uses of the H2 blockers? H2 blockers are used in duodenal ulcer, gastric ulcer, reflux esophagitis, stress ulcers and gastritis as seen in hepatic coma, severe burns, trauma and prolonged surgery, in Zollinger-Ellison syndrome, in pre-anesthetic medication and hyperhistamine. Now coming to the proton pump inhibitors can be a 5-mark question by itself or it can be part of the main question. Classify drugs used in peptic ulcer, describe mechanism of action, uses, adverse effects of OMEPRAZOLE. Now all these proton pump inhibitors are prodrugs. They are inactive at neutral pH. At pH less than 5, it rearranges itself to charged cationic forms, namely sulfonic acid and sulfonamide. It is the sulfonamide moiety which blocks the hydrogen potassium ATPase, also called the proton pump, which is the final common pathway in acid production. So on oral administration at a neutral pH inside the parietal cell, it gets converted to the active form, namely sulfonamide. Therefore, proton pump inhibitors should not be given with antacids. This inactivation of the hydrogen potassium ATPase is irreversible. Therefore, the proton pump inhibitors completely block acid production, that is, they produce a state of achlorhydria. Pantoprazole and rabeprazole can be given intravenously also. So what are the pharmacological effects or actions of the proton pump inhibitors? Gastric acid production is completely blocked. All the phases, basal, cyclic and neurogenic and gastric, completely blocked. There is no significant action on the volume of gastric acid use, pepsin secretion or intrinsic factor secretion. Gastric motility is not affected. There is a moderate hypergastrinemia. The adverse effects of the proton pump inhibitors: nausea, diarrhea and abdominal pain, headache, dizziness, sleep disturbances, skin rashes, leukopenia. There is a potential risk of bacterial overgrowth because acid production is completely blocked. They are hepatic microsomal enzyme inhibitors, so there is a potential for drug interactions. Coming to the uses of proton pump inhibitors, that includes omeprazole, pantoprazole, esomeprazole, rabeprazole. Duodenal ulcer, gastric ulcer, Zollinger-Ellison syndrome, the drug of choice, gastroesophageal reflux disease or GERD, in pre-anesthetic medication, along with megadose pulse therapy with corticosteroids, gastritis and stress ulcers. So with this we stop, and what we need to know is the classification of drugs used in peptic ulcer and mechanism of action, uses and adverse effects of proton pump inhibitors. That will be a 10-mark question. The 5-mark questions will be compare and contrast cimetidine and ranitidine, Or 3-mark question can be advantages of ranitidine over cimetidine. A 5-mark question is proton pump inhibitors. 3-mark question, give reason sodium bicarbonate is not used as an antacid. Or give reason aluminium and magnesium salts are used as antacids in combination. Thank you.